because we do have so many great providers, contractors, organizations. We've got lots with whom we don't have relationships yet, who we think we'd like to broker relationships with, and that'll help us kind of really chart the path of this re-terraforming that this pandemic has done over these last few years.
Hello, my name is Dr. Noha Aboelata. I am the founding CEO of Roots Community Health Center based in East Oakland, and I am joined today by Dr. Karyn Tribble, the Director of Alameda County Behavioral Healthcare Services. Great to be with you today.
Thank you. I'm pleased to be here.
So you are the Director of Alameda County Behavioral Healthcare Services, which oversees many aspects of behavioral health for the county. And I know before that you oversaw behavioral health for our public hospital system, Alameda Health System. How many years have you been in this work?
Well, without dating myself, about 25 years. So I started out at Howard University, research and work for a lot of really important and integral things, and so that for another day. And then I went to Bryn Mawr College for my first master's degree, and then another master's and doctorate at Philadelphia College of Osteopathic Medicine. So came back. So I've been here back in California. I'm from Southern California since I think 2003.
Wow. So you've been in it, and you've really been in the public systems, the systems that are really the true safety net for our community. And you've been doing this obviously before the pandemic.
Yes.
And I mean, I know from the work that we do in Oakland and beyond, the pandemic it affected every single person. I don't think anyone has gone untouched. It's like a global, collective trauma in some ways that I think we're all going through. And so what we saw was just everybody impacted, whether it was your own emotions, maybe you never even struggled with, behavioral health issues before, and all of a sudden, going through things like anxiety or feeling depressed, or whether it was your parents or your children going through something with all of these changes. And I think you and I both know that there was already strain on all of our systems before all of this.
That's right.
So maybe, can I take you back to before? I know sometimes it's hard to remember.
It is. I don't know what happened before pandemic, but absolutely.
Yeah. What were the things you were thinking about then? What were the challenges you were facing then?
I think, what I'll speak to the broader county in terms of that, and then locally, even in Oakland and other south and east parts of our county, one of the major issues that I think we're seeing in the Bay Area is what we were seeing was obviously homelessness. And with that, you see people who are struggling and have behavioral health challenges, of course. We've all seen the rise in opioid use and substance use. Those were things we were working on, and really how we can support kind of in a crisis care continuum. So when people are showing up at our emergency rooms, when people are needing crisis support, emergency support, really responsive, even being in a hospital, acute, being in an inpatient unit. So those were the standards. They were extremely important, but those were the standard day-to-day quandaries that we found ourselves. And this is pre-pandemic. So that's really where our team was focused and wrestling with. And then the pandemic hit. And everything changed, everything, because I think most public systems, and I'm sure in Roots and other organizations know this, and across the nation and world, is that we're not set up to provide immediate support and response to someone, and you're not being disconnected with them. So that sense of how do we reach them when we can't? So on a dime, our system and many other systems, I'm sure your organization, we had to figure out, how do you speak to homelessness? How do you speak to stress and crisis and all of that when you technically can't reach out and touch and connect? So that was pretty devastating, I think, for the whole system. I think when, we and others were able to kind of stand up and do a lot of virtual telehealth and other platforms, and then we in government and many other organizations are essential services, so we had to continue to work in healthcare and behavioral health. What we began to see was first, ironically, an absence of reported symptoms. In other words, one would expect right at the beginning of the pandemic that immediately you saw these behavioral health issues and things, but we didn't. We saw it was almost for lack of a better euphemism, a calm before what we now know was a storm. People weren't returning or going to their providers as frequently. People weren't going to the emergency department. Clearly, there was fear. There was the everything was shut down. Schools were closed. On a real life level, we were not even seeing as much, for example, in the schools in our youth, contact with young people in the way that we had before. Sometimes, quite frankly, we heard from our educational partners and providers, those were the ways that people could reach out to social services if there were issues in the home, because you had teachers that people forget that were actually seeing those things for us and reporting and connecting with us and our team members. Same thing with elder care. You had people who were more isolated than they had been. So it was a strange pause, it felt like, to life. And then slowly but surely, that changed. It changed.
What did that pause do? Because I know exactly what you're talking about. It was almost like a shock to the system, to where it's like, all the connecting points had to pause. Did that cause strain in other parts of the system?
It did, because I think the way people, and this comes kind of through the lens of being a stigma, and I'll just say it that way, where when you say behavioral health or mental health or substance use, there as much as there's campaigning and there's acceptance of that as a part of life, it's still stigmatizing. So when you think of just a hierarchy of needs, I'm in physical pain, or it's pandemic and I'm sick, you prioritize not your behavioral health. You really look to getting other needs met. So what we saw is in some of our providers in healthcare and organizations, that people tried to get through different front doors. They went to their primary care physicians. They leaned on their churches. So again, we saw a lot of public challenge and concern, because those doors began to be closed because of the pandemic. But we found that people were trying to reach us and connect us way differently than they had, not thinking that ultimately I need to go get my behavioral health managed, but I need help right now. I need to talk to someone about my family. I need to talk to someone about the stress that I'm experiencing, that I've lost my job. Our primary care physicians, the docs that usually will treat the common cold, clearly had to don, the experience of working with families around COVID, but we also found that other areas of our system that we hadn't typically partnered with in the way that we do, or we now think of, were being challenged. The other piece that I think was very striking for us is the quality of the crises and issues that people saw. So, for example, we had always responded through emergency issues and for the community on behalf of that. But what we saw that we didn't expect is that when people would reach out in a crisis or show up in a crisis, that crisis wasn't at a 2 or 3. That crisis was at a 12 on a scale of 1 to 10. And we saw that people were more sick, more ill in terms of behavioral health. If they were homeless already, they had been so without care or not knowing how to reach out, or whether they should, trying to quarantine or really look at different ways, that by the time they did present to some of our systems, they were much more in dire straits than we've seen in the past. So just, I guess, qualitatively, people were more impacted, and that we had to pivot. We had to pivot to provide more support, as I said, to the non-traditional doors and partnerships, and hoping our partners, including Roots, who was really a stalwart connection to our public health fight to the pandemic. But we had to lean on them, and then we had to look at, we need to refine and enhance our services to really support those who are much more challenged than they were initially. They can't wait as long for help.
Yeah. So, I kind of hear you, I heard you say the churches, the primary care doctors, the schools. How was it that, it sounds like that is, in large part of the behavioral health safety net in some ways.
That's right.
Are you looking at that differently than before? Or are you thinking about those partnerships differently than before? Is it more of the same? Or how has that kind of, I'll speak for ourselves. I don't know if we all knew how much really the schools were playing a role in food security and in social services connections and serving our homeless young people. I think we knew it, but we experienced what it was to be without it in that shock moment. So I'm just wondering how you're thinking about sort of those partnerships and connections now when we sort of had to lean in so much on that aspect of the safety net during the crisis, or is the thought we'll go back to how we were before?
It is the Matrix. I wish I knew what color pill, but we will never go back. We can't. We have really gone through a door that won't take us back ever. I don't think even when we're stabilized, quote unquote, the pandemic has somewhat resolved. I'll still have a mask probably in my purse, just in case if I'm not feeling well. So I don't think we'll ever change. I think before, we certainly recognized the importance, and I and other leaders had the opportunity, even pre-pandemic, to meet with many members of the community, kind of those who you wouldn't necessarily see as a behavioral health doorway. But we had already started cultivating, okay, what can this be? Let's explore how we can partner, or is there a way that we can do services differently before? And now it's urgent. And now, to some degree, we've created those emergency mechanisms, but it has even expedited our exploration. So now it's just we have to. One of the benefits is, at the state there's CalAIM, which is people can kind of look into it. But I'll just say that it's designed to reshape the service delivery system. And all those different doors and kind of barriers that people have to access services hopefully will be lessened. So it couldn't come it's been difficult, but an opportune time to give us leveraging ability or connections that we didn't have before with our hospital partners. We've already started, even the pandemic, as strange as they are, these Zoom and Teams and WebEx and all these different meetings, but working with some hospital partners. And we've worked in and looked at our mild to moderate, you call in the space of behavioral health, just means people who may not have been the target population, but definitely need help. So yes, I don't think we will go back to normal. I think that there are things that are happening that will help us to re-terraform and re-identify ourselves. I think, and one of the things is it's hard. I think I can only speak as a county director. Just talking to my county directors statewide, is that the challenge that we entered going into the pandemic and even before is that specifically we serve kind of like an HMO. And our target population, supposed to be, is at a more complex level of need. And we're, for people who are uninsured or people who are Medi-Cal, and certainly with certain funding streams that have come out from the state that has allowed counties to pivot. But now more than ever, based on those new partnerships, the doors, the need, the fact that people are not necessarily only going through one or two doors, it is now putting us in a position to really look at how we can serve much more on the care continuum. So we certainly prevention, which we have done for many years, but strategic prevention, more partnership with folks we saw rise to the occasion that may not have had capacity to do, quote, traditional mental health and behavioral health, but sure know how to reach a lot of people. So it is going to force us, and it is an opportunity to be creative. And again, as I said, thankfully there's ways that we can connect our heart with the will. And that was what we're seeing, some of the changes at the state level.
That is good to hear. And so it sounds like maybe we can kind of bring it down to the individual level. So let's say you're a resident of Alameda County, you're going through some things, right? You're feeling stressed. It's interfering with your ability to kind of do your day-to-day. What's the first step? What do I do?
That's a wonderful question. Well, the good thing is now we want to be real. We want, we did it with a loud thud. we redid our website. For us, we are trying to rebrand who we are and how you access care. So there's always, i.e., Alameda County Behavioral Health Care Services. We're always here, looking at who's on deck, what programs we have, how you can call us. And I would say that we also recognize that stigma and the challenge is real, that in the middle of this pandemic, and I think people hear about it, healthcare workers are making other choices and are themselves going through stress and themselves getting burnt out. And so it's changing in a lot of ways. And I say that to say that if you're a person in the community, we have, and others are brokering those relationships with churches, with your primary care physician. Pick up the phone, give us a call. Even if we in our county, I say we, don't do it. For Alameda County, we contract out 100% of our substance use services providers, and all that work is contracted out, and about 85 to 87% is contracted out of mental health. And in between all that, we've also brokered relationships with non-traditional providers, people you would never know. So we are in the process now of just completely revamping the way that, quote, traditional admissions comes. And we've been doing analyses even under this pandemic and getting a sense of what our team members think is helpful. And we've also really been responding and hearing the feedback to our community. So we hope that at some point we can help be that broker and we can receive all of it and help people go where they need to go. And as we're getting there, though, we encourage people to talk to their doctor, reach out to their primary care physician. Even if you have an eye appointment, if you've been stressed out, tell the provider, because what the pandemic has done is if anything, humbled us and remind us that even though it's a health care issue, your behavioral health is part of your health. And so I don't think there's any round door where people can get help. The state has lifted up many different hotlines, phone numbers, texting lines. That's another thing that's been creative. Our department has launched some, especially for youth, because even though the pandemic did allow us to do some virtual support or phone, you take for granted young people. No offense to parents, I'm one, but they don't want to have therapy with their mom and dad in the room. They may want to talk about some really complicated things. So I don't think there's any wrong way to do it. And I would say if anyone's in confused and not sure about it, you can always go to our website, for example, look at our provider website, Roots. Again, we lean on our community partners more so than we ever have, and I think that will continue.
So I like what you said, and I didn't want to lose what you said about, you're going to your doctor that, maybe you go see them for your diabetes. Do you think that I know this might be a hard question to answer, but do you think that enough people have a primary care doctor? Is that part of the challenge, or that relationship with that primary care doctor, to where it's not just about getting your medication refills, but that you'll say that, or that people maybe don't think to speak to their primary care doctor about it? Because it sounds to me like what you're saying, where the county's real, the focus population has been those with more severe things going on. But the average person could have a lot of things going on. And so you're saying that they're not necessarily going to be receiving services directly from the county or within that system, but that there's got to be other access points within the community to help. And so I'm hearing the primary care doctor piece. What needs to be done to really make sure, I think, that people tap into that resource first, maybe as a starting point?
You lovely questions. I had to catch up to you. You said pack a lot of good stuff. I think just to back up a step, I think one of the challenges, and a lot of people use the word stigma, and it means nothing. For example, I can only speak for myself. I'm clearly a Black woman. I don't just have a tan. I'm a Black woman, and in many communities, just having a mental illness or an issue is a thing. And then you go into a door or a space, even with a primary care physician, the word trust, you said trust. I just want to unpack that. It can mean something very different. Not only trusting you with my life, I have to divulge the family business. Do I want to do that? Can I do that? Is there a risk to doing that? Will I be judged? Will my children be taken away? So there's a lot of issues that people have to get through to just ask for help. As you know, most of, quite frankly, the folks that we help are people who have already been overrepresented in many areas of our society, whether it's jail, whether it's homelessness, loss of jobs is just unbearable. So again, as I mentioned before, when you think about what is it that I need, I think the first thing that people need to do to kind of work their way to get there is to realize, if I could just be so bold, it's not that deep. Meaning everyone has this. And the good thing about the pandemic, it has put into place relationships that didn't exist before. We have gotten contacts from physicians and doctors that say, we don't know what to do. We've got people that are showing in our ER and our ED who definitely won't have a relationship. Can you do something? And so when you ask, what are we doing? We literally are trying to create, and I wouldn't get out in front of the county, but we're trying to create some programs that will meet, literally, not euphemistically, meet a person where they need to be and where they can get to. So if it doesn't feel right to make that connection with a provider, or you don't have a ROOPS to go to locally, we're trying to figure out a way to connect them no matter what. And so what that means is all you need to do, quite frankly, is use the real words that everybody's going through. Depression, anxiety, even just nervous, stressed. Those words, if you don't want to come close to saying I have a mental illness, it's okay. You don't have to anymore. You can even say, again, to your faith leader, my spirit is in pain right now. And what it has done, hopefully, at least that's the way we're looking at it, it has positioned us and other organizations in a place of really looking holistically at a person.
Are you enjoying this podcast? Well, if so, go on to Apple, Spotify, or your preferred podcast platform to watch the full podcast. We want to hear from you. Please subscribe to our YouTube channel. Leave a comment. Let us know what your experience has been during this pandemic.
I think something you said in there was interesting, because I think it's been an assumption kind of that everyone is sort of, going through the same thing. And I think what you said was interesting, that some people are thriving and doing well and maybe have more to give right now. And some are really, really struggling. And so it sounds in there like we shouldn't assume everyone's good. We shouldn't assume everyone's bad either.
That's right.
So there's this way of sort of, and that sounds a lot like community, right? We lean in on each other. When somebody's doing better, that person can give more. And so it sounds like we're needing to do more of that, having that ability to make those connections and lean in on each other and pull on one another's strengths. And to do that, though, I also hear you saying, you have to have that. You have to be ready to communicate those things, and you have to be able to do that. And so it sounds like one part of it is, we all don't have to be on all our P's and Q's and be so polite all the time. If you notice something that seems a little bit off with someone, obviously we don't want to go around offending anyone. But I hear you saying, if you notice, if you see something, say something kind of thing.
Yes.
And so that we're all taking on a little ownership and a little responsibility for not only ourselves, but kind of for checking in with one another and really creating that community. And that feels like a positive.
It is.
It feels like a positive. So with all of that, I would say, so we're sort of realizing that the safety net is more than what we maybe thought about it before. It includes a lot of our faith institutions, our community-based institutions, our primary care doctors, our schools. How are you thinking about, I guess, within this next phase of what could those connections be with what really is a very focused and specific purview that I think the county behavioral health has, that, to your point, there's laws around it. It's very much at the very downstream, as we say, sort of at the end of the stream. We want to do way more things upstream. But how do we make those connections better, so that it's not just, okay, well, actually, you got to wait until you're all the way down the stream and then we can help you. We understand that there are parameters around what things can be done through what different systems and so on. But how are you thinking about those connections now that it's just so clear that we need them, we have to have them? What are you thinking about for the next phase?
Lovely question. I think first I'll say, we're trying to think of it humbly. because, what the pandemic has done has certainly still created an avenue for some people to connect with us and give us feedback. But I know that there's a swath of the community who have not had access to even the platforms to give feedback. And, we recently, and, it comes with some chagrin, some folks would prefer we not, but I am committed to checking the pulse of the community. Did we get this right? This is what we're thinking about. Tell us, is this wrong? Is this right? We have been watching the trends. We have been participating. Our staff have been involved. So, we are, and we think the right thing to do is say, okay, this is our idea, for example, and we would like to do this. We are, again, this means that we wouldn't be pausing any of the work we do, but this means that we will try to get input into some of the direction that we're going to. And it's not so much to do the checkbox. And again, we hear that, and it's interesting. As an aside note, one of the things that contributed to kind of the burnout is, and that we hear, and I'm sure you recognize, is that people really probably won't understand until maybe after this just how much people are giving their lives to help fight this pandemic, both healthcare, behavioral health. And so, we try to celebrate as much as we can do, and our providers and people hanging in there, because it's ironic, but they're still shots fired lots of times where we're not doing enough, we're not doing it right, we can't think straight, we don't know what's happening. And we know part of that is the trauma that we're all in. The words aren't pretty anymore, and the daggers are now dipped in poison. But our job is to weather on and to stay focused. And so to bring it back, we've got a lot of ideas. We think that, as I said, we only saw a swath of the community, and we don't know how everyone else fared because, what the pandemic did, we reached up together. We found out ways that we can do the COVID hotels, the contact tracing, the vaccines, and a lot of other efforts. And we saw a lot of things that works. And then we want to do a litmus test and say, okay, this is what we're thinking. And does this make sense? And as I said, the good thing is that we're in a time of change. And so we already have, through some of the funding that the state allows, for those that are aware, Mental Health Services Act and others, give counties flexibility. And we, and even our team internally, are looking at what our research is, looking at what the projections look like for the state, looking at what we currently do, and making sure that, and as you asked before, we can't do it the same way, and we won't. But it's going to be hard to pivot, because what we recognize is, because our systems have functioned in a certain way for so long, there's that. And just like change that we all saw, there is a resistance to change, because this normal that we've done, we've kind of gotten used to it, and eventually we're going to have to pivot again, and that's going to be hard. So we have to think mindfully, especially those of us who can maybe affect policy, about what we do. We can't chase every shiny red ball, because then we'll have all the balls in the air and we won't be specializing it. But it must mean that we have to be intentional, and we have to think creatively, and then we actually have to vet that with people who have been doing it, or others who have been doing it differently, or people who did not show up in any of our forums or any of our doors. How did you fare? What made sense to you? What kind of service? Because we do have so many great providers, contractors, organizations. We've got lots with whom we don't have relationships yet, who we think we'd like to broker relationships with, and that'll help us kind of really chart the path of this re-terraforming that this pandemic has done over these last few years.
Yeah. So, I mean, I hear you saying we have a lot of things. We have a lot of resources in the community. We have each other. We have ourselves. We can build skills. And also that, no, there's not enough also for all the need that exists out there. And so I'm wondering, how are you thinking about that, the landscape? So will there be places? Because I also heard you say you can't, show up and get the service, in the psychiatric hospital and under these laws until you get to a certain point. But what about before that? Is there a place you can just show up and knock on the door? I'm in crisis. My child is in crisis, or Or are we thinking now about new locations or just places where people could show up, maybe just to take a break or just to, before that 911 call has to be made? Are you thinking differently about the landscape, just as we, sort of are, we've got, and I know the landscape includes the digital part too now. So, I mean, that is, that's an extension in some ways. But what about those physical locations, especially in communities that we know have been hit really hard by the pandemic and before that?
Yes, and yes, and yes. One of the, it's a slight pivot, but I think it speaks to you. One of the investments that we think is the right thing to do is we will be through the county, and I'm not getting ahead to because I think we're moving that direction of creating, for example, an African American centered facility that is dedicated to that community that we all can acknowledge, no matter what you think and say. The numbers and the data and the pain speaks for itself, and serving kind of as a hub of different types of services and supports. And we're all of these ideas. So we think we won't say nailed it. After that, we think there's more facilities. There are more things that we need to do. And yes, and the state is also providing some opportunity for us. What's important to us, I think, as a department is that we invest in permanent resources. So, we would like to balance having a both and approach. So, for example, certainly having permanent county infrastructures, and we've got a lot of organizations that have facilities and buildings. So we'd like to do both. And, that's strategic. Because as I said before, most of at least our behavioral health department relies on our providers. But I personally also want us to take ownership and responsibility, permanent responsibility through investment, that this facade, whatever it is, whatever the facility, whatever the service line, the services may ebb and flow depending on what the community need, but we have committed to something that is based on what the community needs, really needs. So I think those are the things that, we hope to do. But yes, one of the things that, has been a challenge. This was pre-pandemic that I didn't mention is, for example, there's a lot of hope that we can bring centers that people can just drop in and need space. My guess is that now with the pandemic, as I said before, qualitatively people are in a different place than they were. Headaches hurt a little more, the more and more stressed as they were, that we'll need to connect potentially those types of locations with, i.e., a roots. Or we will have to connect them with, maybe, I'm making this up, but maybe an adopted spiritual partner or organization in that network. Or we will need to connect them with a social services resource. But I think the one benefit that the pandemic has showed us is that if everyone comes together to do it, we are leveraging our time, our resources, and our support to a particular community or need. And that seems to work. It works well because the county certainly has resources, but cannot be as nimble. When we say sprint, we'll be there in 2 years, and others can sprint faster. So it means that if we do some investments, we need to then look up above those types of programs and make sure that they have an immediate connection. Because if I'm a person in the community, this is post-pandemic, and I come in and I say I'm stressed, I have potentially gotten used to being so stressed out because of the pandemic that pre-pandemic, when I said I'm stressed, I'm just kind of stressed. Post-pandemic, when I say I'm stressed, that's a whole different ballgame. I'll need a lot more support and services than even I may recognize. So that's why we can't do it in isolation. And that's why we'll have to make sure there really is no wrong door, that there is a sponsored community around different programs in the county, and it is they're interdependent on each other. I think that is what we have seen to provide support, and it's been successful, at least on the healthcare side, and there's no indication that it would be otherwise for behavioral health.
So does that mean, I don't mean to read too much into what you said, but does that mean that you're thinking about sort of the neighborhood approaches and the fact that there's connectedness between different things that may not always have been on the county's radar per se, but that are a natural support for communities?
Yes, even regionalized county approaches. That's something we were thinking, kind of pre-pandemic, and now that, even if our data, for example, shows that in this particular community, utilization of this service is low, which is a whole bunch of words that say a lot of people don't go there. It may mean because they're going somewhere else. So if we regionalize it and have neighborhood or community or area where you have different types of sources and there's a way that they can connect, maybe people didn't go there because they didn't know it existed. Or maybe there was no natural nexus. Maybe there wasn't even any transportation. Did we build it where there was no access to public transportation, or did we do it? So it's yes and. It's so really leaning on what's out there in the community, like in a true sense of community. Yeah.
So I'm hearing get community input, creating some community hubs, some culturally responsive hubs, connecting resources that currently exist, and elevating them to where they're supported, and maybe the partnerships are supported as well. How do we know when we got it right? I mean, what are, from your perch, what are you going to be looking at to say we're on the right track?
That's a wonderful question. Well, we, one of the things, we're kind of an unsung hero. I'm very proud. We have a really important data analytics unit. So we look at data. We don't probably sing it and celebrate it as much, but literally with a drop of or push of a button, we can see what happens. I think we have current data sets, but I think we're going to have to think differently. And I think the community is going to have to help us get feedback on that, because I think traditionally, and I'm probably speaking for many community behavioral health departments across the state, you looked at incarcerations, you looked at certainly homelessness, you looked at how many people access emergency departments or inpatient units. That's traditional. I think that there needs to be more. I think people, if you ask someone on the street, are you happy? I think they can tell us if they're happy or not, but there's no metric around that. And I think we should, and we need to be a little more creative about having those, quote, subjective measures of quality, quality of life. I think we have a lot of those data sets internally, but I think we'll have to, figure out what's the sweet spot, really. Income stability can also contribute to a person's success. That actually could have predated a person's venture, sadly, into the legal system. And yet we think the incarcerations around, they're not connected to enough of this. No, actually, I need a job. I need you to get me some more housing vouchers, or I need you to be able to do this or that. So that's what I think, really taking the temperature over time, certainly having a plan and allowing creative methods to help us get there. And so I think we'll know when we get to a good place relatively soon, because I think community will feel it, our client, our outcomes, quote, people will feel better. But I don't think, if I can say humbly, we'll ever get there, if that makes sense. I don't think we'll ever be done, because humans are dynamic and things are changing and things will change. But I feel like we can feel comfortable if the community is getting what they said they needed.
So I think what I hear you saying is that there is sort of, we're in a moment where we can think not just about what services were used or where they were used. That's important. I know we'll have to keep looking at that, but also how a person feels, what they perceive as their quality of life, as being sort of an important indicators to look at in terms of success around behavioral health. To people, are they able to earn a stable income? Are they stably housed? And so it sounds like you're starting to think a lot about the social determinants of health and the other areas that I know that that are easier said than done to really be able to sort of evaluate. So how does that fit in with work around disparities that we know exist within, behavioral health and where people receive their services? I mean, how do you think you'll be able to sort of look at all these things through that lens?
I love how you say that. I'll speak for the department. I'm super pleased that in the pandemic, we created a health equity division. And it was a must pre, it was a necessity during. And so we brought on a health equity officer who works with the units and the managers and parts of our system who actually touch the pulse, both ethnically, racially, culturally, linguistically, in terms of family members and consumers and patients' rights and all that, to help give voice and actually start to make some really key recommendations that are not just based on kind of a one-dimensional area. As you know, the good thing is we now see a lot of the health equity measures that sprung up from the pandemic put a light on things we already knew, but even exacerbated, the disparity that we saw across, the county, the state, what have you. And that's where we want to start, actually. I think the good thing is that we have some really good resources in particular areas, and we have some people who are receiving support already. Now we have to look at the gaps. What did it show us? Who actually stopped seeing us more often, or who actually felt like their voice wasn't being heard? Who was throwing more rocks at us? What neighborhoods needed the most help and support and ideas? So that health equity officer that we have, I won't name her, but we are pleased that, they're part of our team, and they're already actually forcing us to do our own work so that we can actually get out ahead and make some decisions, not based on our own stuff, but based on what the community is telling us. And that's going to be a hard place for us. And I know that our agency as well, at a higher level, is really embracing a whole health equity initiative for us. So again, another good thing, I think, that came from the pandemic, not to mention all the political unrest, the lives that were lost, and all those things that changed. They gave us some knowledge and wisdom.
Yeah, I was going to kind of go there next and, just say that I know for a lot of the population that we serve, there is a disproportionate amount of services provided in the jail. And so we talk about African-American men, and we know that mental health issues can be criminalized, and there's a disproportionate incarceration. And we know we've had not only, I think, George Floyd and, what I do think led to sort of an awakening across the country. Some of us have been in this work, we work on this every single day, but I think much of the country, sort of became aware, at one time. But how do you see, the ability of, mental health services to be able to, and I know this is a complicated question and issue, but to be able to address that fact that we have, disproportionate incarceration and addressing of mental health issues in locked facilities and settings like that? Are there ways that that you're thinking differently about that? Like I said, I know we were all aware of these issues long before I think it became widely known. And then I guess the part two to that question is sort of, did that awakening, do you see that making changes in ways that will help give sort of momentum to the work?
Now my turn to unpack. Yeah. So yes to what okay. So I think where I'll start with is, if we could, and we actually had these real deal conversations internally. And again, during the pandemic, we also created a system of care that is there to actually support and hopefully prevent people who are connected to the law and the legal system at every layer and connection, so that eventually they don't come back or they never get there. If we could wave our magic wand, and I don't say so flippantly, I mean that, there would be no one in jail. Mm-hmm. There would be no one in prison, and there certainly wouldn't be a disproportionate number of people who look like me and my sons and my husband and my cousins and my uncles and my dad in jail. Here's the responsibility, and the authentic part is that, for me as a director of behavioral health, I can't care where you are, how you got there. I have to help you. As a person, I must help you. And what I would hope for is that the community would also see that, as I mentioned before, there are some factors that contributed to those legal offenses that need to be resolved and addressed. And as a community, and I know that our county leaders are really investing in that. From some of the other areas are our probation, our DA, our public defender's office, our judges. we are literally at tables talking through some not only funding questions, but on system change that has to happen. But I say that to say is the day one, which I know you're very familiar with, if I am incarcerated and I leave jail, I still need to get my needs met. And in order for me not to go back, certainly behavioral health is important, and housing, and food, and clothing, and healthcare, and job, and quite frankly, the way the system does or doesn't see me. That's deep and real. And so I think where we come from, our perspective in behavioral health is, and it's a reality that we know that there are people in our community that wherever they are, whether they're in that jail or on the streets or in the community seeking outpatient services, it is unfair and it is not equal and it is not equitable. And therefore, they are at higher risk for suffering from mental health wherever they are. And so my responsibility and our responsibility is to provide support, to help them navigate, to avoid those doors, and then to work with partners such as Roots to find out what's the upstream, what did contribute to this offense. It's not as simple as criminology, and I think we all know that. It is life, it is pain, it is risk, it is affiliation, it is violence, it is a lot of different things. And those are the things that make a difference in the community. A lot of upstream, a respect for the fact that it is not a pathology, it is a blight on a society, to see that people who are most in need often have the worst travails.
So does that mean that behavioral health has the opportunity to kind of work backwards to say,
yes,
this is the population that has been historically or currently sort of harmed or disproportionately represented, and they are more concentrated in this part of the county?
Yes.
And then be able to focus services there. So is that part of the work?
Yes, it is. It is. And it is, if we can, as I mentioned, the system of care that is, really working with people who have that intersection, their job is not just jail. I know there's a lot of attention and focus on that. Their focus is when they leave, where do they go? With whom can we coordinate? They're working on developing kind of a care coordination approach, something that we've seen in other areas, but, people really haven't developed that kind of attention in that way with people who have interactions with the law and the legal system. Is literally a wraparound, not wrapping around by virtue of my offense. And if I'm doing good and I don't reoffend, but wrapping around in terms of what are my basic needs, what contributed to that, and how can I help you have the skills to never go back? Or how can I help you with your new family be connected to pass on intergenerational wisdom instead of pain and trauma? And so we're really trying our best. So our hope, we will probably be, following the population exactly where they go. So if our hope is that if things work over time, because it took us, we all know, hundreds of years to get here for Black, Brown, and other community, our immigrants, our trans community, there's just so much out there in terms of unfairness and pain that if we do our job right, ultimately, we work our way out of a job and we refocus on different issues. That's our goal.
You mentioned the generational, and I think our experience is that so many of these things are generational.
Yes.
The pain, the trauma, and
right.
just the experiences. And I know sometimes the behavioral health system can feel like a closed system. Like
yes.
you're the individual that needs
yes.
us. But what about the generation? What about the children? What about the family? How do you think about that? Is that something that needs to be connected with the other pieces of the system, or something that behavioral health would aim to sort of do more holistically?
Yes to both. I think, the way that in fact, we were literally, we have a unit around on that. And we were talking about, especially to our family members, really being strategic and outreaching and doing even more. And so that the families really see even more, so that there's support. I think we do a wonderful, fantastic job, particularly with our younger children, because of the school and the connection. And most people acknowledge that a child cannot live outside of his or her environment. You don't even do therapy. You do it with a child, but then you have, you talk to family members, whatever that looks like, always. And the shift that has to happen to speak to that is, and that's what I meant by the system itself. It really has to be an ecosystem, for lack of a better term, a whole bunch of different things that make up that person's community. That is what makes a difference. And yes, it means that consultation, in big words, helping the family to recognize what are the stressors, what are the links, or if the identified person that went to jail, for example, what society teaches us is it is inherently something that he or she or they did, and unpacking for the family. No, let's look at how they got there. Let's work backwards. And what are the signs you could recognize when that person is struggling, or what are the things that you unknowingly or maybe re-traumatizing that person to feel a lack of self-worth and a need to be connected or affiliated in a gang because they lack that community in the home. There's a whole bunch of different things, but yes, that, you can't see it, I'm doing backflips. Yes, what you said. There's so many things that you can do. It's interesting. It's not traditional, as you said. It is not the typical way that I think for behavioral health. And I mentioned HMO in the beginning, and I'm hoping that I'm channeling my partner behavioral health directors across the state, is that what most people don't understand is we were initially created to exclude, like an HMO, to say what's covered, what's your covered benefit. And if that benefit's not covered, let's tell you to go somewhere else. And that sea is changing. And again, our state is really trying to chart a new course. So it's really all the things that I'm saying. We have fingers, toes, and eyes crossed. And we are already making changes to be able to support a different approach to behavioral health that will allow us, a bit of freedom to not just be an exclusion, but actually be an included partner. And to we fund them, and we do have different relationship with many different providers, but we can now strategically build a system that includes many different ways to engage and help people that don't mean at their worst or at their most challenged. And it's a novel approach. It definitely takes funding. It definitely takes infrastructure. But yes, that's what we hope. That's really what we hope.